I'm Samir Mehta, the moderator for this session, and I'm delighted to have a wonderful panelists with me, starting from the extreme right, Alfonso Jurado from La Paz University in Madrid. Alfonso, welcome.
It's my pleasure.
Thank you for joining us. From Linares, Brazil, João Eduardo Tinoco. João, you and I have worked together before. It's a pleasure to having you here again. And to my closest, Peter Buzman from Krakow, Poland. First of all, before we even get into the topic, I'd like to congratulate the TCT directors. I think they have done another fantastic job this year. Our topic today is a discussion on coronary bifurcation, the strategies, the various equipment to use, in particular the ultra-thin struts, and of course my favorite topic on ST elevation myocardial infarction. So with those topics, we'll take you through what are some of the tips and tricks you could learn. All my three panelists have a single denominator. They are all experts, there is no doubt, and hopefully we'll demonstrate that to you in their wisdom. Alfonso, starting with you, what is your approach to a bifurcation lesion?
It depends, as you know, the patient and the lesion, but we, as the recommendation says us, used to do provisional stent technique, probably 80% of cases, and it depends the evaluation, the pre-evaluation with imaging, functional test. We perform two-stent technique when it's needed.
Any priority in the imaging which you like to use for bifurcation lesions?
We use both. We use lots of IBUS and OCT. Probably it depends the kidney function, all the features of the patient and the lesion, but we use both.
And doing more and more of left main bifurcations?
We're doing lots of left main bifurcations because our clinicians has a lot of confidence in us, and we do. I don't know the number exactly of bifurcation, but with lots of left main bifurcations.
And what would be your general preferential approach? I'm sure you personalize the lesion, base it by imaging guidance, but for the left main, what technique do you like?
It's more or less the same. We used to do provisional if we can do it, always with imaging. And if we have to use a two-stent technique, I used to do more DK crash, but also culotte or mini culotte. It depends the case.
Excellent. We'll come back to your various devices, your approach to lesion modification, and your preference to stents, and we'll even try to figure out if there is a benefit of any particular stent specifically dealing with the thickness, maybe a thin strut stent or something. But João, last time we were together, we were dealing with Latin telemedicine program. I'll just take a moment to mention about it. A behemoth program providing coverage in South America for 100 million STEMI patients, and was a pleasure working with you. And now you are a proctor for CTOs, calcification. Let's stay though on the bifurcation, a very large part of your practice?
Yes, most of my practice right now, it's complex PCO cases, especially CTO case, and those with CTO is the first step to start a challenging case, and the bifurcations, trifurcations comes together with the PEC, even the calcium and other issues. So we have to have a lot of skills to deal with those situations. We use a lot CTO techniques to go through to the struts, the difficulty. We can use the techniques, improving the two-lumen microcatheters, the wires that you use to recross. we modify a little bit the way that we recross the stents. And of course, the deliverability of the stent, the thickness of the stent, and the thickness to cross the branch, the side branch. It's really important in this approach.
We will come to that in a moment. Peter, you do a lot of complex coronary interventions. Overall, just about moving into a two-stent strategy for most bifurcations, again, unless the bifurcation is truly a small diagonal of an LED, but overall doing more and more two-stent strategies?
I think it depends obviously on the severity of the disease. It depends on angiography anatomy and most importantly in intravascular imaging on the utilization of FFR. From my point of view, I really hate losing side branches. So I really take a good care at imaging of the lesion, at estimating the territory of the side branch. And whenever I feel it might be comprised, I usually start, and whenever that's feasible, after imaging, after functional assessment, I start with the stenting of side branch. So whether this is a clot, whenever that's possible, you obviously need two same size branches, or decay crush or very minimal crush. But that is after establishment that there's a real lesion in the side branch, because I hate losing it. I hate peri-procedural MIs. We know that in clinical trials we're now facing problems with, I mean, it's not a maybe huge clinical problem, but we know that if we cause peri-procedural MIs, even those are only injuries, I would like to avoid it.
So in your approach to doing bifurcation lesions, any benefit you see versus a thick strut or a thin or a ultra thin? And just for our viewers, this session has been sponsored also by SMT, and I'd like to even discuss about their stent, the stent, the Supraflex Cruise, the ultra thin strut. You think there is any benefit for thin struts?
That I believe that ultra thin struts, they provide much more flexible and more deliverable platform. So whenever I decide for two standing strategies, like my predecessor said, I would really like to see that nice passing through the strut cells, nice, crossing the steep angles, and probably thanks to their easier deliverability, it's easier to cross those, cross into the side branch or main branch in terms of culotte technique. In terms of thin strut thickness, you always have to be aware also not only about the morphology of the bifurcation, but also depends upon presence of calcifications. If additionally you have calcifications, these lesions must be, especially for thin struts, thickness stents, it must be very well prepared.
Absolutely. And in doing that, what are you doing more? Still a lot of rotablator?
I do believe that rotablation takes most of the cases, but now with intravascular lithotripsy, I believe the 1/3 of the calcified lesions can be dealt with easier lithotripsy. So as we're getting more and more tools, I think that the facilitation of lesion preparation and can facilitate the bifurcation stenting, basically.
In particular, have you used the Supraflex Cruise for bifurcations?
Yes, I did use Supraflex Cruise for bifurcation lesions. I like it when I use particularly culotte technique because it facilitates crossing into the side branch. In culotte you need to open the side branch with balloon, double kissing, but whenever it's easier to get into the main branch after stenting the side branch, I think that the Supraflex Cruise and the generally thin strut stents can be dealt a little easier.
Also because in parts of there being a double layer overlapping either in the carina or otherwise, better to have a thin strut than a thicker strut there.
I always like mini culottes, mini crush, but in this case, it's anywhere you're gonna have 2 or at least 3 layers of struts. So obviously, the thinner struts, the lesser vessel wall injury, and lesser inflammation and lesser neontimal formation.
You are talking about all the observation noticed in talent study and the 3-year long term. Those were exactly some of the thoughts they had. Alfonso, you were probably, if not the first person who used this stent in Europe, one of the earlier ones, and you have a experience of something like 1,700 cases at your institution, and almost 500 which you mentioned to me you had done.
Probably.
What benefit would you find for the SupraFlex cruise for bifurcations?
I think it's not only the ultra thin strut because the healing is better probably, and the less strut you have in bifurcations obviously is better, but it's also the feasible or crossing to the side branch, not for the ultra thin strut, but also for the only two connectors, regardless the size of the stent. So it's easier to cross, it's easier to post-dilate the side branch, and also the wide range of expansion makes it easier to do pot, because you can, for example, goes with a 2.0 stent goes up to 3.25. So it's easier to do pot.
And all of that is the thin strut. It's not like the Orsiro where you
so
have.
From my point of view, is an advantage of this platform for bifurcations.
Now there is also a very elegant OCT imaging bench testing done comparing 5 different stents with OCT, and this is from Germany, and they focused on the fact that, look, when selecting a stent, we are not focusing on the issue of the accessibility through the stent strut, and there are beautiful images which demonstrate that because of the LDX proprietary shape of the SupraFlex screws, the area accessing the side branch is much larger. Now, again, I have not been in the United States. We don't have this stent, just for the viewers to know. I hope we'll get it soon enough. The company is doing preparing for IDE submissions, but you see that on a practical level?
That was the point of I was saying about the connectors. If you have less connectors, it's easier to cross to the side branch, and it's easier to post-dilate the side branch. And in that study, I think the result was the stent that has only 2 connectors has a bigger cell size, and also it was easier to cross, so post-dilate the side branch. So it's a good point.
Now, I was reviewing some papers, and a lot of the work in some of the registry work has been done with a mini crush technique to demonstrate the favorable attributes of the very flexible ultra thin strut. But you don't limit yourself. You don't think the advantage would be only for a mini crush. To me, it should be whichever stenting strategy used for bifurcation should be helpful.
Yeah, for bifurcations and for any kind of lesions. I think we have some meta-analysis saying that ultra-thin struts are better than the thin or thicker strut stents for every lesion. Probably we have to personalize, because if you need high radial strength, probably you need another platform. But I think SupraFlex cruise is a good option, not only bifurcations.
So you've got, with the advantage of deliverability, the drug is excellent, the biodegradable polymer is important, there is tons and tons of data, and all these are attributes. Any challenge you found? Is there any issue with visibility, longitudinal compression? Or?
No, probably the visibility of the stent. Obviously, you can have everything. If you have ultra-thin strut, you are going to have a worse visibility than other stents. But the other attributes, for me, are very good, and it's a very nice tool to add to our very good platforms we have in our self.
Excellent. So, Alfonso, there are numerous other clinical trials coming up, another 4 major randomized trials looking at elderly, diabetic populations, high bleeding risk, participating in any of them?
Yeah, we have participated in a fire trial. Over 75-year-old patients, MI, multivessel disease, and I think the results will be presented in ESC Congress the next year. And we are now recruiting patients in the multivessel talent. That is a quite interesting study about multivessel disease as well, comparing supervised growth with another platform, using functional test, QFR or FFR, IFR, and optimizing with imaging. So I think the results will be very interesting.
So in addition to the benefits, of course, which makes sense with the high bleeding risk population, I mean, we should probably be able to get even possibly the shortest dual antiplatelet regimen too.
It's possible because if we are talking about thin struts, we are talking about rapid healing, so reducing double the platelet treatment, that we all want to do that. So probably it's a good option.
So both to Peter and Alfonso, and also in Brazil, of course, one of my favorite countries, having set up almost 126 STEMI centers there, and we'll move to STEMI after this question. How popular? I mean, we don't know this stent in the United States. People don't even know this the company, which I call it a medium-sized company from India with a global footprint. You know, they are moving rapidly into structural heart. I saw one of the depictions there with the Hydra structural heart TAVR and occluders. Is this a very popular stent in Europe and in Brazil? How often is this one of your first-line stents?
In Europe, I believe it is becoming more and more popular. In Poland, I do believe it's maybe still, it's not the workhorse device yet, but the penetration is definitely increasing. Cost effectiveness also plays a role here. And I believe that once physicians will get familiar with the use of ultra thin strut stents, it will become more and more popular.
Does a case come to your mind having used the stent for something which is remarkable for you?
Up to now, I use Supraflex, to be totally honest with you, for complex cases because the deliverability is excellent. And I remind myself a case where Impella was not available. I had a patient with low ejection fraction and diffusely calcified and LAD lesion. I didn't want to go for Rota because this was a low ejection fraction. I was concerned about low cardiac output. So I pre-dilated the lesion with NC balloons. I did use some lithotripsy. But in the end, still, the vessel was tortuous and with some calcifications left behind. I knew I had to do the QA case quickly and promptly. So I was able to deliver 2 long stents. As the cruise is known from its long sizes, I was able to deliver rapidly 35, 38 millimeters 2 stents very efficiently. Obviously, we must be aware of some limitations of generally ultra thin struts, stent struts. Especially, we have to be very careful if by any chance we will have to remove it from the vessel back to the catheter. We really need to be, because they're gentle, we really need to be focused that the catheter is coaxial, especially with extra backup catheters, and be really careful when withdrawing. But mostly because currently we use it for complex patients. I believe that that's why it gained my confidence with this stents.
Got it. Thank you for sharing that. Moving on to STEMI, Alfonso and Joao. To me, everything where you're trying to have the shortest, the fastest procedure to have ultra thin strut which travels quickly, is not thrombogenic, the inflammation from the data, multiple data is low. Make sense?
Sure.
For sure, for sure. When you choose, even if we have a bifurcation in a acute MI and you have to deal with some deliverability materials, and we have this SMTP. Right now, you're using about 30% of our case, 30 to 40% of our cases in the complex scenario, because I believe less material we have there, it's going to be better. So it's difficult right now to prove especially in those calls with a lot of calcification, bifurcations, and in my experience, I used to choose before the procedure what kind of stent I'm going to use, because for me the thickness of the stent, it's really important to cross the cells and the side branches. And even this, I used to use a lot the Onyx one, and because the conformability, the sphere situation, it's easier to cross. If you use a thicker strut, it's gonna be more material in that situation that you can have more problems. And even in the STEMI, the thickness, sometimes the approach to use image to check the size of the vessel, even in CTO case that it's unbelievable. The image right now, the precision PCI is going to be the future for me, because I believe that we are going to treat the best way we can, optimizing everything. And I think one of good thing is the thickness of the strut of the stent.
It's a big difference. Alfonso?
In my opinion, the STEMI is probably one of the best scenarios for this kind of stents, because two facts. One is this thing, you need to go fast, you need crossability, a flexible platform, and this is the first thing. You have to go fast. And the other one is that you need a rapid healing. You are in a scenario with thrombus, inflammation, and probably the ultra-thin strut is the best option in this setting. We have the data about BioSTEMI trial with another ultra-thin strut with less TLR against another platform. So probably these results can be extrapolated to supervised cruise. So it's a good option in this setting.
Peter?
I also think that from biological point of view, the biology of the lesions in myocardial infarction is different. So utilization of a biodegradable polymer which bioabsorbs fast might be beneficial. We've seen that previously in a historical leaders trial, which was later confirmed in the trial with Siro, that in the population with patients with ST elevation MI, biodegradable polymers do better.
Last question for all three of you, and look at it makes sense. I think the attributes of ultra thin short the struts, the benefits are obvious, and from your experience it appears that it is not that you're paying any price for it, and it's becoming hopefully a workhorse. Do you think one should be, when dealing with the complex coronary interventions, we've talked about bifurcation, STEMI, do you think just about it can be used for other complex lesions too?
No, I think we can use it in every lesion, but probably the thing we were talking about before, you have to personalize all the patient, the setting, the lesion, the scenario, and we have very good platforms in ourselves. So probably this is one very good option, but I think we will still personalizing the decision.
About the same, can be used for most complex lesions?
For sure. The length in Brazil, we have the length at 38, most of the stents, and 48 for the.
Does that also provide you financial a little?
Yes.
Cost
financial.
is also important.
I think it's growing a lot, the use of that stent in Brazil, because the public system using a lot
Yes.
because we have to cost. It's really important in Brazil.
Very familiar there, and the cost
Yeah,
is a very
yeah.
important. Final words from you, Peter.
So,
Supraflex screws for coronary interventions.
so for most of the complex coronary interventions, especially those challenging ones, however, we've talked a lot about what are the lesion types for this stents. However, I'm aware of the disadvantages of, in some setting, of all ultra thin stent thickness struts. Number one is left main. I do believe that we need, a little
more strength.
a little more strength, a little more strut thickness. So it is not my first choice for left main stenting
Completely
or large vessels with calcification.
Excellent. Look, I think it only balances everything, which I think is critical. And I think we'll end the note, end the lecture on presentation on this note. All three of you have been wonderful, and I hope our viewers have gotten some tips, some benefits, in particular if they are going to be using different choices. Consider ultra thin strut. I think it has numerous benefits for these lesions. Thank you all, and it's a pleasure chairing this session.